Hi everyone, my name is Sarah Mueller and I'm a clinical pathology resident at Mass General Hospital in Boston. Today I'm going to talk to you about a series of patients with translocation 4q12, 12p13, ETV6 rearranged AML without eosinophilia that were incorrectly presumed to have ETV6-PDGFRA fusions on the basis of FISH, which led to failed trials of imatinib. I have no disclosures. Two of my co-authors, John Iafrate and Long Lee, have partial ownership in ArcherDX. First, some background on 4q12, 12p13 translocations in hematologic neoplasms. This translocation is most often seen in AML with a few published cases of other myeloid neoplasms and eosinophilias. It's rare, even in AML, with an estimated frequency of less than 1%. And at least in AML, it's associated with poor treatment response and relatively short time to relapse. Molecularly, the 12p13 partner is almost universally the ETS family transcription factor ETV6. There are a variety of ETV6 fusion partners on 4q12, including PDGFRA, CHIK2, GSX2, and a long intergenic non-protein. So this translocation came to our attention in the context of a 72-year-old woman with aplastic anemia and AML who was status post bone marrow transplant. And we encountered her on relapse 12 months after this transplant. At the time, she had about 18% peripheral blasts. And the blast immunophenotype is not the focus of this presentation, but her CD7 positivity and MPO subset negativity has been associated with T412 AML in previous publications. G-banding was performed at Brigham and Women's Hospital and showed a new 4q12, 12p13 translocation that was not present in her pre-transplant AML. Before I show you the results of FISH for this patient, I wanted to go over the probes that we use. The Abbott 4q12 Tricolor Rearrangement FISH probe kit is a commercial kit that's very commonly used to look at rearrangements in this region. The 4q12 region is very dense, with a span of 7 genes covered by 3 probes. The green probe targets SCFD2, the orange probe targets LNX1, and the aqua probe targets the 3' end of PDGFRA and KIT, which are very close together. A normal nucleus will have 2 tricolor overlap signals with green, red, and blue in close proximity. And the kit was designed to pick up an interstitial deletion of LNX1, which generates a FIP1L1 PDGFRA fusion, shown here, that is associated with chronic eosinophilic leukemia and is highly responsive to imatinib. In this case, you would see 1 normal signal and 1 overlapping green and aqua signal. But many labs also use this kit to characterize translocations involving 4q12. And this is one of our patients from this series, showing 1 normal signal, 1 SCFD2 LNX overlap signal, and 1 separate aqua PDGFRA signal, which suggests a breakpoint somewhere between this CHIK2 and proximal part of PDGFRA area. So now that we've covered the FISH probes, here are the results of the Abbott Tricolor 4q12 kit in our index patient. So the partial karyotype shows a normal 4th chromosome with a normal tricolor overlap, and a normal chromosome 12 with no 4q12 material. The derivative chromosome 12 has SCFD2 only, and the derivative chromosome 4 has SCFD2 only, and the derivative chromosome 12 has PDGFRA only. LNX1 is presumably deleted in this rearrangement. So she was presumed to have an ETV6-PDGFRA fusion based on these findings, and a recent paper that had detailed a series of AML patients with ETV6-PDGFRA fusions diagnosed on the basis of similar findings, again using this Abbott kit. As a result, they trialed imatinib, which targets PDGFRA in addition to the Abl tyrosine kinase. And unfortunately, imatinib failed and her blast count continued to rise. This was understandably pretty confusing to the team, so they submitted her specimen for targeted RNA sequencing. So the targeted RNA sequencing platform we use at MGH is based on anchored multiplex PCR. Our heme fusion assay is a panel of genes that are known to be rearranged in hematologic neoplasms that's periodically updated based on the literature. And as you can see, we're in version 3 right now. For the purposes of this translocation, it covers the first 6 exons of ETV6, as well as the 4q12 genes CHIK2 and PDGFRA. For our index patient, on sequencing, we detected 1 in-frame ETV61 SCFD2 exon 5 fusion, which was probably a splice product of this out-of-frame fusion. And functionally speaking, it probably behaves as an ETV6 loss of function because the functional domains of ETV6 are downstream of this breakpoint. The functional role of SCFD2 in this is unclear, There's not as much data on SCFD2 function in general, let alone in hematologic malignancies, but it's known that ETV6 loss of function can play a role in leukemogenesis from cases of deletions and truncations. There were also some out-of-frame GSX2 ETV6 fusion reads, which together with the loss of LNX1 probe on fish suggested deletion of this area occurred as part of the rearrangement. We manually inspected the coverage of the PDGFRA gene and the sequence alignments, and there was no evidence to suggest a fusion involving PDGFRA. So after the index case, which is case 1 here, we retrospectively identified 4 other cases of AML with the T412 karyotype and performed targeted RNA sequencing on archival material. All of the patients had different histories, including relapsed AML, AML evolving from CMML, AML from MDS, and de novo AML. The immunophenotype was not necessarily consistent. Some were CD7 positives, others weren't, but most were MPO negative. The most important feature was that none had eosinophilia in the bone marrow or peripheral blood. And here's the molecular data. All of the cases had the 4q12, 12p13 translocation, and most had FISH analysis with the Abbott 4q12 Tricolor kit. On sequencing, we identified identical in-frame ETV6 exon 1 SCFD2 exon 5 fusions in patients 1 and 2. And another in-frame ETV6 exon 1 CHIK2 exon 4 fusion in patient 3. There are only 5 reads here because this was sample was from 2008, unfortunately. And the remaining fusion calls all involved GSX2. The important points here are that ETV6 was involved in all detected fusions, and PDGFRA involvement was not detected. Again, we inspected PDGFRA coverage and alignments for every patient. So for the 5 patients, at least 3 were given imatinib. The index patient was on imatinib for 4 weeks, and as you saw, her blast count continued to go up during that time. She was switched to decitabine and venetoclax, but passed away 4 months after diagnosis of relapse. Patient 2 came to the Dana-Farber Cancer Institute for diagnosis, but we unfortunately don't have follow-up on his treatment. Patient 3 was on imatinib for 3 weeks, but did not respond and died 6 months after diagnosis of spontaneous bacterial peritonitis. Patient 4 was on imatinib for 20 weeks and had a blast count that climbed from 70 to 90% over that time. He died at 5 months. And then for patient 5, the clinical team was going to give imatinib, but we were able to alert them that there was no actual ETV6-PDGFRA fusion before they started, so they started her on azacitidine and venetoclax instead. It's been 5 months since her diagnosis, and she does appear to be responding. So to summarize this table, imatinib delayed conventional chemotherapy by 3 to 20 weeks in patients that had no real indication to receive imatinib in the first place, and all 3 patients who were trialed on imatinib passed away. Finally, I want to put our case series in context of the literature. There are 17 papers describing hematologic neoplasms with this translocation that were confirmed by either sequencing or FISH or both. The table is small and busy, so don't worry about trying to read it, but there are a couple of things I want to point out. The first is that many of the original papers used lab-developed probes to confirm the 4q12 rearrangements. In around 2010, Abbott's VISIS 4q12 Tricolor fish probe kit started showing up in the literature. And as we discussed before, the kit was not really designed for this purpose, and the 4q12 region is too dense for this kit to accurately identify breakpoints. The second thing I want to highlight is that only 10 of the 17 papers, which represents 11 of the 38 cases, confirmed that the 4q12 partner gene, confirmed the 4q12 partner gene was sequencing, usually Sanger sequencing in the context of publications. So of the 11 cases that were confirmed by sequencing, there were 5 ETV6 partner genes, 5 cases of CHIK2, 3 cases of PDGFRA, 2 cases of GSX2, and 1 case of this long intergenic non-coding RNA. Finally, I want to point out that there are 4 cases with eosinophilia highlighted in red. 2 were chronic eosinophilic leukemia, 1 was hypereosinophilia, and 1 was a myeloid neoplasm with eosinophilia. 3 were confirmed by sequencing to have true PDGFR fusions, and 2 of them were trialed on imatinib. 1 was successful and the other was unresponsive, but the unresponsive fusion did not contain the PDGFRA kinase domain, so it's not unexpected. So putting our data together with a literature review, all 3 sequence-confirmed cases of PDGFRA fusions had eosinophilia, and all of the cases with sequence confirming a lack of PDGFRA involvement did not have eosinophilia. So 14 cases total, that's 9 from the literature and 5 from our cohort. So to summarize, sequence-confirmed ETV6-PDGFRA fusions have not been identified in patients without eosinophilia. The Abbott 4q12 Tricolor rearrangement kit lacks the resolution necessary to identify breakpoints in the 4q12 region, despite being used commonly for that purpose. Apparent ETV6-PDGFRA fusions identified by FISH analysis in 4q12, 12p13 translocation AML should be confirmed by sequencing. To put this in a visual format, the current practice is to use the Abbott 4q12 FISH kit in cases of T412 AML. And if positive for a so-called ETV6-PDGFRA fusion, the patient is given imatinib, whether or not there's eosinophilia. And then when imatinib fails, sequencing is performed, and more than likely a PDGFRA fusion is not detected, explaining the imatinib resistance. Instead, we simply suggest that any T412 AML should be sequenced early in the diagnostic workup before imatinib is considered. This could be targeted sequencing or whole transcriptome sequencing, any platform that will confirm the precise ETV6 fusion partner before therapy is initiated. I want to thank Valentina and Paula for making this first observation in the index patient and inviting me to be a part of this project. And Alex Farhani, who's a tech at the MGH Center for Integrated Diagnostics, for doing the lookup to identify patients for this series. And I look forward to hearing your questions. Thank you.